Thank you, everybody, for attending this workshop this morning. It's great to see so many people interested in wound care. It's great. I'll see if I can get this to work now. Aha. Okay, so the brief I was given for this workshop was what's new in wound care, including the principles of wound management, lower leg wounds, skin tear management and dressing products. Now that's an awful lot of information to cover in a couple of hours, including morning tea. So it's going to be fairly brief on each subject, but please, if you are unsure of anything, please do ask questions. I don't want you to go away wondering about any subject that we're covering. So what's new in wound care? So I thought, okay, well, I'll Google what's new in wound care. And all that came up with it was a heap of new dressing products, not actually wound management, new things. And as we all know, what's new to one person isn't actually new to another person. And I still have people come up to me that are amazed about moist wound healing. They still think we should be keeping wounds dry. And this was actually developed before I was even born, and I'm pretty old. So, yeah, what's new to one isn't new to the next person. So all of these documents here were released last year. These are all brand new documents. The consensus documents and the position statements were all released in Florence last year in September, and then the International Wound Infection Institute and the Wound Australia Standards, they were launched in November in Melbourne. So as we speak, the European Wound Management Association is being held in the Netherlands, and there'll be more new documents being released there. So it is evolving every day, every minute there's something new coming out. So what I thought we would do this morning, we'll have a look at wound assessment and what the latest is in wound assessment. We'll have a look at leg ulcers and skin tears, as was requested. Then we'll have morning tea, and we'll have a look at dressings. Now, during the morning, I'm going to give you all some case studies to work on, and I'd like you all to break into small groups. You can work individually on in your small groups and the case studies, and then for the final hour, we will join up together and we will all then discuss what you have done with your case study, because it is a workshop, which means that you're here to work as well. Okay, so some things haven't changed. The principles of wound management are still the same. And how many people have heard of HIDE? It's been around, yeah? It's been around quite a while. So this is a structured assessment of the person, including the wound. And by using the HIDE acronym, it means that we're all doing the same thing. We're not, if you've got more than one person working in an area, it means everybody is using that same assessment structure. So we're looking at history, the examination of the wound and the person, any investigations that may need ordering or results that we already have. We can then make a diagnosis of what either caused the wound or what is delaying that wound from healing. And then after we've done all of that, we can look at a management plan and how we're going to intervene. So it's still about looking at the whole person, not the hole in the person. So history, it's a holistic assessment. What happens to the person influences the wound healing, or otherwise, the wound not healing. So we're doing this holistic assessment to find out the medical condition of that person, and also to find out the ability of the wound to heal. As we know, not all wounds will heal. Some can be healed with other interventions. So some people might need some surgery, vascular surgery, or other types of surgery to enable that wound to go on to heal. That's why we're doing the holistic assessment, to find out this information. Of course, people have lots of comorbidities these days. People are living longer, people are getting bigger, people are staying at home for a lot longer. And so there's lots of things that can influence that we can't necessarily change, but we can work with. People that are on certain medications, these medications can delay the wound healing, and it might be that we can talk to the GP or whoever is the primary health professional looking after that person about reducing, say if the person's on steroids, maybe we can reduce them steroids for a short time. If they're on methotrexate or chemotherapy, maybe it can be reduced or changed to a different drug to allow that wound to heal or to start healing and then resume their current doses. Have they got enough tissue perfusion? Is there enough oxygen getting to the wound? And that might be because they have chronic or obstructive pulmonary disease and they're not taking in enough oxygen. Or it might be they've got peripheral vascular disease and so there's just not enough oxygen being transported to that particular area. Also, their lifestyle. Do they smoke a lot? If they're smoking, every cigarette that they have stops the wound from healing for a couple of hours. So if somebody's smoking 10 a day, which isn't very much for some people, that's 20 hours of the day that wound isn't healing. So if you talk to people about smoking, just don't say, well, you need to stop smoking. If you explain it to people, even if they can cut down 1 cigarette a day, it's going to make a difference. And do they have an infection? Systemic infection? Have they got cellulitis? Have they got osteomyelitis? Or is the wound infected? Again, it's going to stop the wound from healing. On to E of our HIDE acronym, examination. So again, we're looking at a systematic approach. And this systematic approach helps with our assessment. Make sure we're doing the same thing all the time. So this triangle of wound assessment is new in 2015, so this is new in wound care. And this helps us to do our systematic examination of the wound. So what the triangle looks at is it looks at the wound bed, it looks at the wound edges, and it also looks at the peri-wound skin. So how many have heard of the TIME acronym? Yeah, TIME's been around for a long time, and it is absolutely still relevant, but given I was asked to talk about what's new, this is more recent than TIME. So what these acronyms and these assessments do is they look at preparing the wound bed for healing. So it's about wound bed preparation. So if we look at the wound bed itself, is that what sort of tissue is in the wound? Is it granulation tissue? Is it nice and healthy that we want to maintain? Is it sloughy and we want to get rid of that slough? Or is it necrotic? Or is it epithelializing? And then when we look at the exudate, what sort of exudate is it and how much is that? These things are important because they can tell us what's happening in the wound. If we look at that exudate and it's thin and red or slightly yellow, that's fine. We're happy with that. We don't want any changes. However, if that exudate is thick or purulent or green, then we know that there's something going on there. So if you look at that diagram, you can see an arrow on the middle, the thick, cloudy, purulent. That is heading towards infection. So if we look at that last box, the localized infection, all the symptoms in that left column are localized infection symptoms. And in the right column, it's more systemic infection. So in the left column, we can probably get away with using antiseptic dressings, antimicrobial dressings. And in the right-hand column, that's when we need to start looking at systemic antibiotics as well as an antimicrobial dressing. And then we move on to the edge of the wound. What does the edge of the wound look like? Is it macerated? If it's macerated, then there's a high chance that that wound bed will increase in size very quickly because that is damaged tissue and it will break down quite quickly. Is it dry? If the edges are very dry, then the new epithelial cells are unable to slide over each other to cover the wound bed. So we need to add a little bit of moisture to that. Is there undermining? Is the wound a lot bigger than we initially thought it was? Again, we need to fill that gap so that we can encourage wound healing from the bottom. And are the edges rolled like that? If the edges are rolled, it's usually a sign of an underlying infection, and there's no wound, sorry, the edges are unable to go from that rolled appearance to slide over the wound bed. They actually need to be altered to make them nice and flat so that the new epithelium can roll over the granulation tissue. And then we move on to the peri-wound skin. Again, it can tell us quite a lot about what's happening there. Is the maceration? We haven't got a very good dressing product on that wound on the left-hand side because that wound is, or the surrounding skin is very, very macerated, very moist. We've got some dry skin in the middle. We've got hyperkeratosis. All that needs to come off. We've got callus. Now, if that callus is on a diabetic foot wound, then that callus is going to cause more pressure and is going to increase the size of the wound very, very quickly. And have we got eczema on the wound? I had a patient say to me this week that my compression bandage caused his cellulitis. So I thought, that's interesting. I've never heard of compression bandages causing cellulitis before. So I asked a few more questions of him, and what actually happened was the compression bandage caused an irritation. So he scratched that with his dirty fingernails, and he gave himself cellulitis from scratching the leg. So, which probably started off just from a rash in the first place. So if we have got a rash, we have got eczema and it's itchy, we need to address that. Sorry. Would you put zinc on underneath? Yes, you can do. Yep, yeah, absolutely, yeah. So moving on to investigations, wound swabs. How often do we do a wound swab? We probably do them far too often, and all the research says that we do them far too often. If somebody's got a wound infection, then it needs to be assessed and detected clinically, not by a wound swab. So a wound swab is great to tell us what bugs are living in the wound and what antibiotics we need to treat it. However, a wound swab will not indicate that it's infected, because it doesn't know the person. You looking at the wound and all the signs and symptoms can say whether the wound is infected or not. Bloods, do we need to do any bloods for that person, or have we got any recent blood results for that person that can tell us things? So if they've got an elevated CRP, they've got an acute infection. What's their albumin and protein like? Are they eating enough? Is the nutrition balanced? Because if they're not eating enough protein, then the wound is going to be delayed in healing. Also, low protein levels are associated with an increase in pressure injuries. What's their hemoglobin like? Have they got enough red blood cells to carry the oxygen around their body? So these are all systemic things related to the whole person that we need to be looking at regarding the wound healing. If the person has had a wound for quite some time and we have provided best practice wound management and it's still not healing, maybe we need to look further. Maybe we need to do some more investigations, such as a biopsy. Is there a malignancy there? As you all know, skin cancers are very, very common in Australia, and just because somebody has had a skin cancer on the face but not on their leg or on the hand before doesn't mean to say that they won't get one in that place. They're more likely to have a skin cancer, a second skin cancer if they've already had one. Have they been overseas? Have they been to the tropics? Have they got some underlying fungal infection there that isn't obvious to us? And these things will show up on a biopsy. Also radiology, have they got osteomyelitis? If it's probing to bone or if there's exposed bone, well then we treat it as if they've got osteomyelitis. Have they got a foreign body in that wound? Something that we can't see, something that's a bit deeper. Here in Tassie especially, because of this beautiful cold weather that we have, we often get people dropping logs of wood from the wood heaters. They drop the log on their leg or on their foot. They end up with splinters of wood deep in the tissue. And it's not visible, but it could be seen later on when the wound's not healing. And do they need an ultrasound, an arterial or a venous ultrasound, to tell us, have they got compromised arterial circulation in their lower legs? And not everybody will need all of these, and some people will need none of these. Some people will need occasional ones. But certainly if you've got access to recent bloods on your notes, then certainly have a look at them and take it into account. And if you haven't got any recent investigation results, talk to the GPs about maybe ordering some. So once we've done all of these, then we can make a diagnosis, hopefully. But we can't always make a definitive diagnosis. Sometimes it's a case of, well, it could be this or it could be that. So let's treat the most obvious first, and we'll give best practice management with that first provisional diagnosis. And if it's still not healing after a set amount of time, we'll go on and do further investigations. So, for example, on a lower leg wound, we may start with compression bandaging because it's the easiest and cheapest thing to do, less invasive. If it's not healing, then we may go on and do a biopsy later down the track. But it's not our first line treatment. So consider the different things it could be. There's nothing wrong with saying, well, I'm not sure, it could be this, this, or this. And then after all of this, we can make a management plan. So our management plan looks at controlling the underlying cause, or trying to fix the underlying cause if we can. So again, if they've got a venous leg ulcer, then we need to put compression on that leg. If they've got a pressure injury, we need to relieve the pressure. If they've got a diabetic foot wound, we need to control their diabetes a little bit better if possible. We also need to look at offloading, look at their footwear, and obviously podiatrists are the best people to do all of that. And we need to manage the local wound environment, which is going back to your time, your wound bed preparation, and your triangle of wound assessment. And just remember that not all wounds are healable. We like to think that we can fix everything, but we can't. And generally, patients are happier once they know that their wound can't be healed. If you say to them, we cannot heal this, but we can manage it, what are your main issues? And then them issues may be the smell, there may be the pain, it may be the leakage. Whatever is important to that person is what we're trying to control. And of course, whatever the issues are may change from 1 week to the next. But if we've got a non-healable wound, then we're looking at patient concerns. So this is our management plan. It's a bit of a busy slide, this, and I will give you a copy of the triangle of wound assessment on your tables. So again, looking at the three points of the triangle, the edge, the peri-wound skin, and the wound bed. Okay, now it's your turn. I will hand out some flyers. Well, I won't, Kathy will. What we'll aim to do Okay. I've just been told that you'll all be emailed a copy of this, but you can actually download them all free of charge anyway from the internet, but yeah, so you're going to be sent a copy. So what we'll do is we'll work in probably groups of 3, and in the back of each booklet is 3 case studies. I'll come round and tell each group which case study that they're going to be working on. What I'd like you to do, initially, you've got butcher's paper and pens on each table. Just look at the patient history from your case study and write down, so if you write down the side H-E-I-D-I, but at the moment we're just looking at the history and the examination, write down what points of that patient history are relevant to the wound and what you see in that wound bed and what you would like to change in it. For example, if that wound bed is covered in slough, you might want to remove that slough. If the wound bed is 100% granulation, then you might be happy with that and you just want to keep status quo and you don't want to change anything, you just want to maintain what's already happening. So if you look at, when you're looking at the examination and the wound, look at the wound edges, the peri-wound skin and the surrounding skin, and if you can describe them under E, and I'll give you 10 minutes to do that, and okay, off we go. Okay, we'll move on now, if everybody's just about there. We'll move on to leg ulcers. This poor little chap has got a few problems. How many times have you heard this? People say it all the time. Oh, it's not an ulcer, is it, nurse? It's just a scratch, or it's just whatever they think it is. So how do you define whether or not it's an ulcer? There are a couple of definitions, but these two seem to revolve around 3 months time frame. So if the patient has had a chronic wound for 3 months and they've had best practice treatment on that wound and it's not healing, then yes, it is an ulcer. These are the most common types of ulcers, and these are seen, this is from like all over the world, and I'm sure wherever you work, it would be exactly the same. I looked at our stats from the Royal Hobart Hospital recently, and ours, sorry, that's my alarm to say the 10 minutes is on. Sorry. So I had a look at stats from the Royal Hobart Hospital, and ours is very similar to this. The only thing is that's not recorded on this one is we see a lot of lymphedema these days, and I'm sure that you would also be seeing a lot of lymphedema. As our population gets bigger, then we're finding that we're getting an awful lot of secondary lymphedema related to the obesity. So yeah, they're not actually listed on there, but they are quite common, becoming more common. So typical presentations, where we're going to find the different types of wounds commonly. So if it's a venous leg ulcer, it's going to be in the gaiter region, in the lower third of either leg. If it's arterial ulcer, it's going to be below the level of the blockage. So generally it's found lower down, but it could be found anywhere. If they've got a fairly high up blockage, it could be higher up the leg. And neuropathic, always on the feet. A couple of people mentioned ABPI to me, and I'm going to talk about this first because it is absolutely relevant in anybody that you look after that's got a leg ulcer of any description. So it's a screening test that can be done in primary health very easily, very cheaply. It's sensitive, it's about 75% correct. It's non-invasive, you can bill for it on Medicare, and it is effective. So the ABPI is calculated by checking the blood pressure on both of the arms and on the dorsalis pedis and the posterior tibial. You then calculate, you divide the higher of the ankle pressures by the higher of the brachial pressures, and that will give you a number. That number is only part of your whole assessment. So just to make it a bit clearer, the little handheld Dopplers, does everybody have one of these where they work? No? How many people do have one? Okay, so probably half or just over half. Does anybody do ABPIs? Yeah? Yeah, okay, good, excellent. You do need to be trained how to do it. It's not just, oh, we'll just give it a go. There's lots and lots of things that can alter your readings. So you need to be aware of what can alter the readings rather than just pick a number and say, oh, well, that's it, that's fine, that's what the machine said, it's okay. Electronic machines. There are, yeah, a couple of people have got the electronic machines. They are around, they're very expensive. They give you a printout of the waveform and of the calculation, so therefore you can bill through Medicare with it. However, they only calculate numbers. They don't take the patient into consideration. So you still need to be aware of the patient, the overall assessment of the patient, and not just take that number for gospel. Oh, where are we going? Sorry, this is testing me. So we'll just have a look at normal lower leg veins and have a look at how it all works. So if you think about, we talk about calf pump movement, and when people are walking, the muscles around the veins press on the veins and shift the fluid back up the leg. So if you look at all them muscles surrounding them veins, you can see how contraction of that muscle is going to really, really press on that vein and assist with the venous return. %90 of venous return is through the muscle pump action. That includes the veins on the plantar surface of the foot. So when people are standing up, if they're walking, that is compressing the veins on the bottom of the feet, and again, it's assisting with the venous return. Also, as people breathing, if they're taking deep breaths, it causes a negative pressure in the thorax, and again assists with the venous return. So lots of walking, lots of deep breathing is really, really helpful. If you've got people sitting with their legs in a dependent position, it's no help whatsoever. And also you find people, a lot of our elderly people, they shuffle. They don't walk like you and I do. There's no calf pump action as they're walking. They're just shuffling. So again, they're going to get lots of lower leg edema. So how does the venous return work? We've got valves in our veins. I'm sure you all know this, it's just a bit of a reminder, that's all. So we've got valves in our veins that are non-return valves. Two little flaps attached to the walls. As we get the compression of the muscle, the blood flows up, the valve slams closed, and that stops the blood flowing back down again into the previous section. Then the muscle contracts, the blood flows up to the next section, the valve closes, and it stops it flowing backwards again. And that's a picture of normal valve opening, a normal valve closing, and then an abnormal valve. So you can see on that the right-hand side picture, the valve isn't closing properly. So every time that muscle action occurs, the blood flow will go up, and then some of it will come back down again. And that's why you get the swelling in the lower legs. One step forward, two steps back. So what causes the valves to be damaged? It could be from a previous blood clot, it could be from varicose veins, could be from trauma. So when we get this swelling in the lower legs, and you get the associated changes, which we'll talk about in a minute, then that is considered chronic venous insufficiency or venous hypertension. So you've got high blood pressure in the veins of the lower leg. So this is a typical venous leg. We've got obvious varicose veins there. This may be caused through trauma, as I say. Could be through surgery, DVTs, or chronic venous insufficiency. So if people have had any of these issues, then they're more likely to have a venous leg ulcer. And these, again, typical presentations of venous leg ulcers. They have lots of exudate, irregular in shape, usually quite shallow, but they may be deep. They may be sloughy, or they could be granular, doesn't really matter either. Could be just one wound, or it could be lots of wounds, and they could eventually join up to be one large wound. They could be painful. Often people say venous leg ulcers aren't painful, but they usually are. And the pain usually occurs in venous leg ulcers when people put their feet to the ground, which is the opposite of arterial. And there usually is edema. It could be red, could be dermatitis. Atrophy blanche is on the picture on the left-hand side. You can see little white stars. That's atrophy blanche, and it is caused by a problem with the microvascular supply, and it is excruciatingly painful. People will often say that it hurts so much just there, and they'll point to it, and on first glance you say, well, there's absolutely nothing there, there's nothing to see, there's no wound there, it shouldn't be painful. But if you take a closer look, you will often see these little, just like little stars, and a few weeks later, maybe a few months later, there may be a wound there. And it is very, very, very typical in people with venous disease. Lipodermatosclerosis is where the leg is, I'm sure you've all heard of an inverted champagne bottle leg, where you've got a very narrow ankle, like the picture on the right. You've got a narrow ankle, you've got a wider calf. And that narrow ankle is very, very hard. The tissue is really hard and woody. You can't compress it. And that is typical of somebody with long-term venous hypertension. And they usually have normal pedal pulses, and an ABPI between 0.8 and 1.2. Now, just going back to ABPIs, just because somebody has an ABPI in the normal what's the word? Range, thank you, in the normal range for that disease doesn't mean to say we've got that it definitely is that. There are things, as I said, that can alter it. These things might be you've done the reading and the room is cold or the room is too hot. The person's had caffeine just beforehand. The person's a diabetic, so they've got atherosclerosis. The person has chronic renal failure, and they've got, again, atherosclerosis, the hardening of the arteries, so therefore they're not compressible. Diabetes, lots of things that can give you an altered reading. So that's why your ABPI is only part of your overall assessment. It's not the be-all and end-all. So location, again, venous always in the lower leg. Arterial ulcers caused by atherosclerosis. So a normal artery, you've got the blood flowing very well, and then you've got a blocked artery. you've got minimal blood flow. So if you imagine you've got a very narrow artery and then you do the wrong thing and you put compression bandaging on that, it's probably not going to be very beneficial. It's probably going to cut off the circulation, which is why we need to be really, really certain before we put any compression on anybody. So if we look at somebody's history and they've got any of these things on their history, then they're more likely to have peripheral vascular disease. So if somebody has a centralized cardiovascular disease, they're more likely to have a peripheral vascular disease. When we look at smoking as well, don't just ask, are you a smoker? Because they may have stopped smoking an hour before they saw you. Ask if they've ever smoked and when they stopped smoking. So often they stop, no, just when I walked into this building, I stopped smoking. So yeah, it is, as I said previously, it is very, very relevant in wound management. And these are typical arterial ulcers. They could, as I said before, they're on the lower leg and they are below the level of the blockage. So some of these are in the gaiter region, but obviously they've got a blockage a little bit higher up than that. And the main characteristics of an arterial wound, they're quite different to a venous wound. What's described as punched out, so if you think of when you do a punch biopsy and you've taken out a little biopsy site, it's more that sort of shape. So you've got a deeper, more circular wound rather than an irregular, shallow wound. They are often painful, but not always. And the pain in an arterial wound is when the person elevates their legs, generally. Not always. But generally they elevate their legs, and then normally when you've got your legs down, gravity assists with blood flow to your lower leg. When you elevate your legs, gravity no longer helps. So therefore, if you've got a narrowed artery, then you're more likely to get a reduced blood flow, and that lack of blood flow will cause the pain. They're usually small and deep, but they could be large and deep too, depending on how old the wound is. They could be necrotic, they could be granular on the base, they're all different. They usually have much less exudate than a venous wound. When we're looking at the surrounding skin, it could be pale, it could be dusky pink, it could be blue, it could be quite cool. Often hair loss below the level of the wound. Again, don't presume because somebody has no hair on their lower leg that they have an arterial wound. It might be that they've never had hairy legs, or it might be that they've shaved their legs that morning. So again, it's just a simple question, have you ever had hairy legs? And if they've never had hairy legs, it's really, it's not relevant that they have no hair. Often you find people with arterial wounds, their nails are different on the foot with the arterial blockage. So as we know, as we get older, toenails get thicker and harder, more horny and difficult to manage. But if you always compare the two legs and see the differences, if you notice that the foot with the wound on it, the toenails are worse than the other foot, then that is another indication that they've got an arterial problem in that leg. You may or may not be able to feel their pulses. Often people will say, oh, they've got foot pulses, it's fine. They don't have an arterial problem. That doesn't actually mean that they are fine, and it certainly doesn't mean that they've got enough blood supply to be able to tolerate any compression on that artery. So if anybody says to you, oh, yeah, they've got pulses, put compression on, please don't do it without doing a full assessment. If you look at all the best practice documents, they will tell you that it does not a foot pulse does not indicate adequate circulation to tolerate compression. So do you... What, sorry?
If you have mixed vascular, so venous and arterial, how do you make a decision whether to compress or not?
Hang on, you're jumping the gun. Okay, so with an arterial, your ABPI would be less than 0.8. And yes, you can compress. You can compress above 0.6 to 0.8. However, you would do reduced compression, and it's probably better for a vascular surgeon or a wound specialist to make that sort of decision rather than just going ahead and doing it. Intermittent claudication, do people know what this is? Come across it? Yeah, so this is another indication of arterial disease. You'll find that somebody can walk a set distance. It might be 1 block, it might be 4 blocks, it might be 10 metres. And then after walking that distance, they get pain in their calves and the lower legs. That pain is relieved when the person stops and sits down. That's what's called intermittent claudication. And the reason for it is because, exactly as we've already said, they've got reduced circulation. The muscle, as the muscle is working, it needs oxygen, and it's not getting it because you've got reduced circulation. So it causes pain. When the person stops, there is less need for that oxygen to the muscle, so the pain stops, goes away. So it's a really, really good indication. It's usually quite a late indication though. So by the time they've got intermittent claudication, the arterial disease is usually quite bad. And they probably need to see a vascular surgeon fairly quickly. So mixed aetiology, venous and arterial. Of course, we are people, we're not machines. And nothing comes without something else. There's always another indication. So the main characteristics of mixed could be a combination of both. It depends which is worse. So this leg has got signs of venous disease. It's got hemosiderin staining, which is the brown staining around the wound. You can see that they've got what's called ankle flare in the instep. You can see the veins there. You can see the wound looks quite small and round, but it's in the gaiter region, which is venous. They've probably also got cool feet. They've got a combination of both. So it's a matter of treating what you can treat. So yes, you need to treat the venous disease. You need to put some compression on, but depending on what their ABPI is, can they actually tolerate any compression? And as I said previously, yes, they probably can tolerate some compression, but it's a case of reducing it down to what is tolerable for them. And I'll talk about compression shortly, about ways that you can make it easy for the patient to manage at home. So in a nutshell, this is how we manage them. So if they've got an ABPI of less than 0.8 or more than 1.2, please refer on to a wound specialist or a vascular surgeon or whoever you have in your area, wherever you work. If they have ABPI of 0.8 to 1.2, that is considered normal venous etiology, providing they're not a diabetic or they don't have any signs of arterial disease. So if it looks like a venous ulcer, they've got a normal ABPI, treat it as a venous leg ulcer. And you should all have a copy, and you'll be emailed a copy of the venous leg ulcer flow chart. So you should have one on your table anyway. And this is taken from there, and you can download this free from the Wounds Australia website too. So treatment, venous, we apply compression, and there's thousands of different types of compression we can use. There's hundreds of different types. So we can look at bandages, we can look at tubular bandages, we can look at wraps, we can look at stockings. And on the table, just down at the front there are examples of most of these things, feel free to have a look and have a play with them. Arterial treatment, no compression. On an arterial wound, so look at them toes at the top. That person has obviously got very, very bad circulation. We do not keep that wound moist. We keep that wound dry until told otherwise by a vascular surgeon. Once that wound is wet and moist, then we can introduce infection into that wound, and we're going to then cause far more problems than the person's already got. I think they've got enough problems to start with. So them toes, what we can do with them is just apply betadine to them, keep them dry, and keep them non-infected, and the toes will probably auto-amputate, or else a surgeon will remove them. For a healing arterial wound, then we keep it moist. It's exactly the same as all other wound bed preparation. Keep it moist, promote granulation tissue. And once we refer to a vascular surgeon, of course, they will probably be able to stent that artery, possibly be able to, depending on comorbidities. Maybe the person isn't suitable for any procedures, in which case it becomes what's known as a palliative wound, so a non-healing wound. And of course, we always look at pain management with all of our patients. Diabetic foot ulcers, little bit different. Essential that any diabetic with a foot ulcer is seen by a multidisciplinary team, and most areas do have some sort of multidisciplinary team. Here in Hobart, we have a high-risk foot clinic, and we have all of those professionals working at our high-risk foot clinic. We talked about the non-ischemic ulcers and the ischemic ulcers, keeping them dry. Pressure offloading for ulcers on the sole of the foot is essential, and again, your high-risk foot clinic or your multidisciplinary team can manage this. Podiatrists are experts at doing this, and it might be that they use orthotics in the shoes, or that they prescribe specific shoes or casts for the person on a temporary basis, or they may just use podiatry felt, which is just the stick-on felt that they use for a temporary requirement. Urgent referral to the multidisciplinary foot care team. Deep ulcers, so anything that probes to bone or joint or tendon, urgently needs to see these people. Any ulcers not reducing in size by 4 weeks after best practice treatment. If a person has no foot pulses at all, if they've got cellulitis, or if they've got Charcot foot. Okay, back to your turn again. So we'll spend another 10 minutes and we'll look at investigations that you may want to either find the results for your patient, or you may want to order investigations for your patient. And we'll look at what you think the diagnosis is for your patient. And go. Okay, we're going to go for coffee now, but just before you do, please take time to go and have a look at the stands, the tables around the perimeter of the wound, of the room. Talk to the reps that are stood there. They very, very kindly come in early for this presentation so that you can talk to them, you can have a look at their products, and you can discuss any issues you have with them. What we're going to do after is have a look at what sort of dressing you're going to put on your wound. Therefore, it's timely to have a look. So, okay, off you go. Enjoy your morning tea, and we'll see you in half an hour.